Mance, I'm ready whenever you are.
I'm ready too. We should be recording. I think I've got everyone accepted into the lobby. So go ahead and just let me know as you need me to advance. I think I need to reshare my screen. Now. Yeah, it stopped sharing. Let me reshare and we'll get that right back up for you.
Well, good afternoon. Good morning, everybody. Sorry about that. I love computers. I love when you have all these problems on the day that you're supposed to talk. But we're trauma people, so we're flexible. I'm Jane McCormack, and I'm a trauma program manager from New York. My accent gives me away. I'm very happy to have been invited here today with Amanda Truelove. Usually she and I have dueling accents when we talk together, but Amanda's not going to be here today. You're just stuck with me. Slight change in plans. We can go to the next slide. So the problem is I'm going to have to say next slide all the time because that's what's not working. There's some chat in here too that the sound is echoing. I don't know if that's something we can do. So just a reminder, cameras off, listen only mode. Please use the chat function if you have any questions or technical difficulties. Thank you. And I put my email there as well. If you have any questions afterwards, I'm happy to try and talk your way through it. Next slide. So we have some pretty simple objectives today. We're just going to review pre-existing conditions, try to differentiate when possible pre-existing conditions that are present on arrival from hospital events. Sometimes all of these seem pretty obvious and end up being kind of confusing. So we'll try to offer some differences. Next one. So, when we think about complications or events and present on arrival or pre-existing condition, often it comes down to this chicken or the egg, right? This is a partial list of things that I think could be hospital events or conditions present on arrival. But as I was driving into work today, I was like, there's probably more, like STEMIs, right? We have patients who have their STEMI at the top of a flight of stairs and then fall down the stairs and have a subdural. So people do present with all of these conditions, both from the injury event, pre-existing conditions, and then events after. So that's sort of the challenge. Next slide. So pre-existing conditions, some people call them comorbid conditions or comorbidities. So if that's terminology that you see, that's what they mean. We're talking both about past medical history and sometimes past surgical history as well. Like, has someone had a coronary bypass? Have they had a lot of peripheral vascular surgeries on their legs, for example? And so we'll talk a little bit about all of these different conditions and why we think they matter and what they do matter to the registry. Next slide. So if we think about outcome after injury, right? How is somebody going to do? There's a lot of variables that go into that. Clearly, the mechanism of injury is important. We know that penetrating injury has higher morbidity and mortality than blunt injury. We know that high-speed events transfer a lot more kinetic energy, so a fall from height has more morbidity and mortality than a level surface fall. We know that the severity of the injury, right? A grade 5 spleen is worse than a grade 1 spleen. We know that we'd rather have an injured spleen maybe than an injured brain, right? So all of these things affect outcome. Certainly, as trauma people, we know the timeliness of care is important. We know the level of resources and the right resources. But also the other thing that really affects outcome is the status of the organism or the human body at the time of injury. Next slide. So all of the trying to collect pre-existing conditions is really trying to describe the status of that human body at the time that the injury event happened. So I'm not going to bore you with too many studies, but just to prove that I didn't make this up, a couple of studies. This is an older study from the Journal of Trauma, but it talked about that mortality increased with age across all levels of severity. So if you're going to be a trauma patient, try to be a trauma patient when you're younger, right? Your outcome's going to be better. And that this effect seemed to be most important at mild or moderate injury. So if you're really devastatingly injured, your pre-existing status is a little less important than at mild and moderate severity. Next slide. So here's another one. This is a different study, took a look at the patients who develop a complication or a hospital event and then recover from it, right? So if they recover from it, that's called a rescue. If they don't recover from it and they die after the complication, that's called a failure to rescue. So they compared adult patients and found that those who were unable to be saved, those we failed to rescue, were different from those who were rescued. And that difference had a lot to do with pre-existing status: diabetes, congestive heart failure, myocardial infarction, and presence or absence of dialysis. So slightly different study, but again, the importance of getting those pre-existing conditions correct. Next slide. So I think this is my last study. This one took a look at geriatric patients only, right? The 70 to 79-year-olds and then the over 80. And it tried to predict outcome and said that injury severity and comorbidities alone did not predict mortality. And we sort of know this, right? This came out of palliative care, but this is saying that that's why with elderly patients, we have that goals of life discussion, et cetera, et cetera. For our point today, what this study did was they looked at not just diabetes, hypertension, et cetera, but it was the combination. It was having like one or two or three or more pre-existing conditions, that sort of trifecta that seemed to mostly affect the outcome. And if you think about it, this is what our TQIP reports do. Our TQIPs, if you look at the data, if you ever get past the charts and actually look at the grids of data, it'll tell us what percent of our patients by each age group or by each cohort have more than three or more pre-existing conditions. So again, just interesting things to know. Next slide. So in the trauma registry, I'm finally getting to the point. In the trauma registry, these are the fields that really help us to describe the human organism, right? So some of these fall more into the category of like social determinants of injury, right? Things like race and ethnicity and socioeconomic status as measured by our zip code. These things all are going to affect the individual's outcome. But what the NTDB has come up with is 30 of these pre-existing conditions, right? So that's really what we're going to focus on today. Next slide. So the question about these 30 is, why these 30, right? Because sometimes we look at patients and we see their charts, or you see the patient and you're like, wow, this person has so much going on. And then when you try to assign the pre-existing conditions, maybe there are not that many. So they pick them because they pick them, expert opinions, right? The group that controls the NTDS and the data elements. And I'm sure they get a lot of solicitation asking for different definitions or whatever. But it really is expert opinion. And the other thing is sometimes the ability to collect and report on it. So there might be other things that could affect outcome, but maybe we wouldn't be able to collect them or report them very well. If we go to the next slide, we can see some of those. So this is just, again, a partial list of maybe other things that could affect outcome, right? But something like poverty is hard to track in our data. We don't know, right? We have zip code of home, but that's about it. Maybe we don't know HIV status, or maybe we don't know if this child's in foster care or whatever. You can probably think of, 10 more things that may affect outcome. But certainly, we have the 30 that we have. Next slide. So the danger or the challenge of this is that if we don't report these things correctly, we end up with skewed data. If I'm working off a different definition than you are, then we're not going to have accurate or correct data. We then can't compare our data, which means our risk adjustment isn't going to work right. And that the ultimate result of that is we're not really going to know how our trauma center is doing. If I report everybody has all these pre-existing conditions that they really didn't have, then my over-reporting has skewed my data in one way. And if you under-report them, you've skewed your data in a different way. Next slide. So the question is, why is this so difficult, right? Why is it so hard? Well, these are my opinions of why I think they're hard. Some of these are fact, and some of these are Jane's opinion. One is that, the definitions change. There are annual updates every year to the National Trauma Data Standard. They usually come out over the summer, right? And then late summer or early fall. And that's our opportunity to ask questions about it, talk with our registrars, talk with ourselves about how we're going to capture this data element. And then January 1 of the next year, that definition goes into effect. Some of the things that we struggle on are perhaps socially stigmatized conditions and perhaps are underreported by patients and by clinicians, and we'll have some examples of those as we go. Patients are notoriously poor historians. We've all had those patients who, deny trauma. You tell them they have a fractured hip and they say, oh yeah, I did fall last week, right? So poor historians is one thing. The clinicians, I love my clinical staff, but they are not great documenters sometimes. Part of it is just the nature of the work. It's busy, it's fast paced, there's a lot of patients. Part of it is that in trauma, we have so many different disciplines. So we might have emergency medicine and trauma surgery and neurosurgery and orthopedic surgery and cardiology and who knows what else. And people might have slightly different definitions or interests in reporting pre-existing conditions. And so we might end up with some differences. Next slide. So I think there's probably some bias in reporting pre-existing conditions. Again, these are my opinions. But I think every once in a while you get one of those charts where some, PA student or medical student or somebody wrote like the 18-page history, and it's just beautiful. It tells you everything you need to know. There's always the patient that has, the family member who keeps track of everything, and you get a really nice, concise history. Other people, not so much. Every note you open, it looks a little bit different. I think definitely the sickest patients sometimes get the worst assessment of their pre-existing conditions. Those who are rushed immediately to the OR, those that maybe die in the emergency department before we have a chance to find their family or even to identify them. Certainly cases that have gone through PI because there's been an issue with the case, those get looked at by a lot of people. The registrar looks at it, the program manager looks at it, the PI coordinator looks at it. And so you have a lot of different eyes to look at it and maybe say, oh, we found, more information in all these other spots in the chart. And so they might be a little bit better reported than other cases. Next one. So in terms of sources, but when we talk about the data dictionary, we're going to talk about the data hierarchy. The data hierarchy that's written in the data dictionary is, in my opinion, a good place to start, but it is certainly not the be-all and end-all. Pre-existing conditions are best documented, my opinion, in things like an H&P or consult notes, particularly notes that consultants that speak to a specific discipline. So a psychiatric consult note is going to be invaluable in telling us about those pre-existing mental health disorders. A cardiology consult note is going to probably tell us a lot about the hypertension and the anticoagulant usage. So if you have one of those are probably a good source. Sometimes care management or social work or physical therapy or any of the rehab disciplines, sometimes they're giving you the best assessment of those activities of daily living. What kind of home support does this person have? Do they use a walker, right? That kind of stuff that will allow us to assign pre-existing conditions. So expand the sources a little bit is what I would say for this. Next slide. So in terms of hospital events, I'm taking a little bit off the side here. I'm going to get back to pre-existing conditions. But the thing with hospital events is, particularly with the electronic record, we just are drowning in data. And, you cannot read every note in every chart. You would never get a chart done. So for events that occur in the hospital, I think a quick place to start is a discharge summary. If it's decent, if it's not a very good discharge summary, it's not going to help you. Anything in the progress notes, the consult notes, the nursing notes, but again, that could be a lot of reading if you don't have it. So you look for hospital events if there's an unexpected outcome. This is a hip fracture, came in on a Monday, got operated on Tuesday. They didn't leave for 2 weeks. That's a patient we have to go look and find a hospital event for, something to explain the reason. But again, it's like a time utilization thing. You can't read every single note, so you're trying to use your time efficiently, but hunt down like where you're going to find these things. Something should explain really long stays. Something should explain unexpected outcomes. All right, now I'll get back to talking about pre-existing condition. We'll go next slide. So here we go, the 2023 NTDS pre-existing condition list, and hopefully this is everyone's favorite document. If you're a trauma registrar, this is a document that you have bookmarked on your computer. You await its distribution every summer. I'm old-fashioned. I like a hard copy of it. I put notes in it. It's dog-eared. This is definitely the most used document in your registry. Next slide. So here we go. We're going to kind of click through these fast, Amanda, as we describe them. So first one is the description. It's going to tell us what the definition means, right? So you could do next slide. It should come up. Yeah. Next slide. Okay, so then we have our element values, male, female, non-binary. Now, bear in mind, on your registry software, you might not have this. You might have A, B, and C, or MFN. Like, you might have something different, but when the data gets mapped to the National Trauma Data Bank, it's 1 for male, 2 for female, 3 for non-binary. That's the schemata of how this data goes. The green box is telling us additional information. And in the NTDS, sometimes this additional information is pages long, right? Well, let's talk about the VAP definition, right? Pages long. But this tells us, this answers a lot of our questions. We don't get to vote on this. We don't have an opinion on it. This is not up to me to decide. This is, this is the rule book. Next one. And then we get the data hierarchy. I mentioned the data hierarchy. This is a good starting point. Where are you going to find information about the patient's sex? Well, probably on the face sheet or the billing sheet or the admitting sheet, right? That's probably the best thing. And in your hospital, it's probably one of these, right? But we have all seen charts where a patient in different progress notes, one note says male, one note says female. The people cut and paste garbage all the time, right? We see it's the right extremity, then it's the left. So we have to have a system to try to deal with conflicting data. Last one here is just the edit checks. So this is what tells us what the problems are going to be when we go to download each field. So if you think about this, the field for patient sex cannot be blank, and it cannot be not applicable. The only option you have could be unknown or not documented. That seems hard to believe that that could happen to me, but that's probably your only option. So again, each page has these things. So before people go posting questions to the Google group and getting some opinions that perhaps are incorrect, pull out the data dictionary, read through this. A lot of times the answer is right there. All right, next one. Next slide. Okay, so a couple of things about additional pre-existing conditions from the 30. So the National Trauma Data Standard gives us the 30. Sometimes our trauma centers want to collect additional data elements. And there's pretty much two ways you can do this. One is you could use the ICD-10 non-injury codes, which is nice because those codes are very rich. There's a lot of depth to them. There's probably a code for what you want to collect. The challenge is that if you're not a coder, if you're not a medical records coder, if that's not your background, sometimes training on non-injury codes and getting comfortable with reporting on them can be a bit more challenging. So your center may want to do a custom data field, or maybe your state or your region or your health care system put together a field or two. But those are pretty much the two ways that you can collect additional pre-existing conditions. Next slide. So as an example, let's say your hospital, your trauma center wants to collect information about vaping. Well, if you go to ICD-10, there is a code, U07.0, vaping-related disorder. It's nice, it's specific, it's easy. So you could collect that if you had a spot to put non-injury codes in your registry. The other way is maybe you would add a custom field. The challenge with the custom field is, are you going to do vaping, yes or no? Do you want to do vaping a lot, a little? You did it once. What you don't want to do is put it in a free text box, because anything in a free text box is impossible to report on. It just becomes impossible. We don't spell the same. We don't type the same. You really, in your registry software, want to avoid a free text box. So perhaps an internal pick list that says current vape user, something like that, might be more meaningful than vape yes, no, vape once in a while sometimes. But if you do this, no matter what you do, you have to develop basically a data dictionary page for each field. So that if I was going to be your new registrar, you would be able to give it to me and say, here's how we fill out this field. Next slide. So, again, I just want to sort of shout out that this is a joint process. You can't collect good registry data, and I can't run a trauma center without registry data unless we're all doing this the same. So everybody wants it correct. Like the people that are documenting in the medical record are not trying to make your life hard, but they also don't want to do extra work. And we all come at this from very different ends. We know different things. So it is important that we educate each other. I'm a big believer in having registry staff spend some time once in a while with the clinical teams just to say, hey, did you know that for us to assign the pre-existing condition of X, we have to have Y in the chart, right? So, just always, I'm a big believer in that. Next slide. So, this is a page that Amanda found when she was putting some slides together, and I just want to point everybody out to it. I have a bunch of these in the talk. These come from the 2023 Data Dictionary FAQ. This is on the American College of Surgeons website. And you don't have to be a TQIP center to access this data, but they take questions about the registry fields. So Amanda lovely pulled up a lot of ones for us on pre-existing conditions. So here's the question that says, can I report other pre-existing conditions that are not defined? And the answer is no, meaning that no, they're not going to accept them. But yes, you can collect them, right? You can collect them, it's just they're not going to download to the National Trauma Data Standard. Next slide. The exception to that is COVID. In January of 2020, the NTDB, TQIP, ACS, everybody said we have to track this virus that is causing havoc throughout the world. And so they made a decision that U07.1 non-injury ICD-10 code will be collected along with the injury list, and it downloads along with the injury codes. So I'm hoping that here we are in 2023, everybody should be well familiar with this, but I'm going to guess that there's probably a few of you saying, wait, what? So, again, that's just an example of how the registry software could be updated kind of quickly. They changed the download, and we did something that was pretty important. All right, so next slide. Here's what we're going to do. I'm going to ask everybody to, you need a piece of paper, and you're just going to write 1 to 10. We have 10 true, false questions. It's like a test your own knowledge. Yes, I am a New Yorker, but I am a Green Bay Packer fan, and it is my goal in life one day to go to Lambeau Field. That's why I have a picture of the Green Bay Packers in my talk. All right, next slide. Here we go. So we're going to do 10 questions, true or false. A patient with an advanced directive limiting care is excluded from TQIP analysis. This isn't like an interactive survey. Sorry, we're not that fancy. You're just going to keep track of it for yourself. Next slide. The answer to this one is true, okay? And this is in the TQIP reference manual materials, and it tells us that exclude patients with pre-existing advanced directive to withhold life-sustaining interventions. So that's, again, a good lesson in why do we read the reference materials. When you say, I put 1,000 patients in TQIP and I only reported on 750, this might be one of the reasons why some of your patients fell out. Next slide. So what does the Advanced Directive Limiting Care Data Dictionary page tell us? Well, in 2022, it changed, right? There was a pretty significant change. And this is all written down here in this additional information, and I'm not planning to read these to you today. But I'm just going to say that the change in 2022 was it's not having a document, it's having advanced wishes to restrict the scope of treatment. So somebody who has a DNR, DNI who comes in and undergoes surgery because the family and the patient rescinded for that time period, they would not get this assigned. I would just also point out that an advanced directive limiting care does not equal care withdrawal, right? Many patients come in without advanced directives, and then through the course of treatment, discussions with the team, maybe then care withdrawal is made. They're separate things. And just because you see a palliative care consult does not mean they get this pre-existing condition. All right, next slide. So what are we up to? Another couple more questions about it. This is another example of where this came up in that online FAQ. So again, they're talking about this first question is that it's not the paperwork, it's if life-saving treatments were limited, right? So it's not just the presence of the document, it's the restrictions, if any, on care. It also clarifies for us that we can take this from past admissions. So if you came in as an advanced directive limiting care in March and then you fell again in April, we can assume it's the same. Next slide. So again, those FAQs are really important. They're good to test them once in a while. Pull them up and read them when you're sitting there on your lunch hour. All right, number 2, true or false, pre-existing condition of prematurity should be assigned to patients under age 5. I wish I had music I could sing, but if I sing, you'll all leave. All right, next one, true or false? The answer is false, right? So the cutoff for the certain conditions is 15. There is a list of pre-existing conditions on the left that we only report on patients 15 and over. And then on the right, congenital anomalies and prematurity are only reported on pediatric patients, 14 and under. All right, one more slide. So it's just important that we know that. There's also this list, and again, I thank Amanda for this slide. If you may want to print this one and hang it in your work area, but this is the list that's reported on all patients, and those in brown are ones that require medication to be assigned for the code, right? So that's not the only requirement, but that's a nice summary slide as well. Next slide. All right, true or false? The pre-existing condition of prematurity should be assigned to a 12-month-old born at 36 weeks gestation. All right, next slide. I'm not giving you too long to answer these because they are true, false. So this one's false. And this is to really get at the issue of you really have to read that data dictionary. I don't have that good a memory anymore. I can't remember each and every one of these things. But the prematurity is 37 weeks. The myocardial infarction is within 6 months. Steroid use within 30 days, right? So each one of these has a slightly different time constraint on it. Look them up, right? That's why your data dictionary is normally sitting there, normally very dog-eared, because you've been in it every day. You're looking up something every day. Next slide. All right, number 4, the pre-existing condition of CVA or stroke should be assigned to any patient with a documented history of CVA. Think about it, think about it. We'll go next slide, and the answer to that one is false, right? Again, if you read the definition, it tells us with persistent residual motor, sensory, or cognitive dysfunction. So some people have a stroke and make a 100% recovery. They would not be assigned this. Other people, yes. So my tip to this would be sometimes you find this best in like physical therapy or care management, where somebody says, you know, she's always had right-sided weakness ever since her stroke in 2007 or whatever. Sometimes you find this information in a bit more detail there. Next slide. How's your score so far? You guys keeping score? All right, here's another little tip. Sometimes these conditions, these pre-existing conditions cluster. So if someone meets the criteria for a CVA or stroke as a pre-existing condition, then definitely give them a really careful look for functionally dependent health status, because functionally dependent health status has, if anybody needs help with the activities of daily living, which are bathing, feeding, dressing, toileting, and walking. So walking with a cane or walking with a scooter meets the definition of functionally dependent health status. So again, always kind of think of these things that cluster and make sure we're assigning all of the pre-existing conditions correct. Patients that live in a skilled nursing facility, I would always give a really careful look for their functionally dependent health status. There's a reason why someone's living in a skilled nursing facility, and they're probably getting assistance with at least some of these ADLs. You need to be a little careful with SNFs and independent livings and assisted livings and all those. A lot of times the documentation is like, came from Twin Oaks or just transferred in from St. Barnabas or whatever, St. Mary's, and you're like, we don't know what that is. Or within that facility, there could be both independent living, assisted living, and a skilled nursing facility. So if you're gonna really look at those patients to see what it is they need assistance with so that you can assign this, just be careful you know what you're looking for. All right, next slide. Here we go. Pre-existing condition hypertension should be assigned to a patient who is prescribed an antihypertensive meds but does not take it. If you've been doing this job a while, you've been doing this a while, you know, this one's probably changed over time. We'll go to next slide. So currently the definition is yes. We would report this yes for non-compliant patients, right? And it says it down here in the additional information. If you go to the next slide, there's also some chatter about this in the FAQ, right? If they're managed by diet and exercise, it does not meet the definition. That's a relative change. Prescribed and administered it during the hospital, but not at home, then they would get a no. So again, there's some variation to this, some of this, that's what you see. I just saw a question in the chat box, so I'll go back to functionally independent health status for a blind person. I would assign it. I would. I mean, if they need a seeing eye dog or walk with a cane or whatever, I would assign that a yes for functional independent health status. Next slide. All right, blood thinners, everybody's favorite one, right? A patient taking Plavix, Eliquis, or warfarin should be assigned to the pre-existing condition of anticoagulant therapy. Next slide. You all know this one. Yes, of course, right? So this one gets challenging only for a couple of reasons. One is the list of medications changes seemingly daily, right? And this is a nice list they put for us in the data dictionary, but I need to know the brand names because very few people call them by their generic names. So my data dictionary page would also have handwritten in all the other names of the drugs that I'm probably not going to remember. So whatever you need to know. The additional information down here says that anticoagulation must be part of active medications. And if we go to the next slide, there's been some questions about that on the FAQ, right? They're not compliant in taking it. We still give them a yes. They asked for some help with defining active, and they do the same old, they must have been prescribed. I have to tell you, this is one we've had discussions about in my trauma center because if a patient says I stopped it 7 days ago in preparation for a colonoscopy and then I fell, they're really not on the anticoagulation med, right? So again, my advice is with those kind of things, be consistent. Just be very consistent within your center. Sometimes I don't have perfect answers. All right, next slide. Number 7.
Jane, there was a question in the chat too right now. If a patient comes in and tests positive for COVID, are you still using the U07.1 or 7777 for COVID under other comorbidities?
No, what they've told us to do is to put it as a COVID positive. So I would put the COVID positive. Yeah. I don't know what you mean by other comorbidities. There's only 2 lists. There's the injury list that currently allows us to put the thing. So there's no procedure code for COVID status. Maybe there's a procedure code for a COVID test. But how we communicate COVID positive is using that ICD-10 code to include it in our injury diagnosis list, and that's what gets downloaded to the NTDS and to TQIP. All right, we could chat about that later if we need to. All right, number 7, pre-existing condition steroid use should be assigned to patients taking inhaled steroids. Yeah, good one. No, false, right? So again, it tells us we're only interested in oral or parenteral steroids within 30 days, right? And taking them for a chronic medical condition. So we're going to exclude all of the others. Good one. Next slide. Number 8, the pre-existing condition, other mental personality disorders should be assigned to a patient who takes Xanax. Right. Next one. Yeah, no, false, right? So in 2023, and I think many of us are still in the deep learning phase of these, in 2023, we were given these 5 new diagnoses, pre-existing conditions to track and treat. But all of these require that they be present prior to injury. They're only reported in adult or over age 15 patients, and they need a diagnosis documented in the medical record. So bipolar, post-traumatic stress disorder, schizophrenia, schizoaffective disorder, and then the other mental personality disorders, and there's a list. So this is new. I mean, right? We've only been doing this for 6 months now, 5 or 6 months. We can go to the next slide. I think that these are going to be a little bit challenging for trauma centers. My hunch is that we're probably underreporting some of these. There is a reluctance on the part of non-psychiatrically trained staff to document some psychiatric diagnoses, right? People just they don't want to get into it. They don't know too much about it. If you're working in a center with strong availability and good psych support, then you might get psych consults on a lot of these patients, and those clinicians might feel a bit more comfortable in making appropriate diagnoses, in using appropriate terminology. But if you're in a center, and I think most centers in America right now are struggling with psychiatric support, right? This has been a big post-pandemic thing. There's just not a lot of help out there. Then I think it's probably going to be underreported. Yeah, I saw in the chat, again, just anxiety and takes meds, probably I would not assign it. What's required is the diagnosis. Can we just go back one slide, Amanda? Sorry. Yeah. So you're talking about in this upper right corner, right? This other mental personality. So antisocial, dependent, generalized anxiety disorder. I don't think it's so much focused on the word disorder or the word generalized, but I think it has to be that it's really a diagnosis, that somebody there's a diagnosis and they're being treated for it. And again, same thing for major depressive, we're all struggling with the same thing. I don't purport that I know the perfect answer. I do not speak for the National Trauma Data Bank or for TQIP. So these might be questions that you should also pose to them to make sure that they're hearing it from all of the different centers, what the challenges are with these. And again, I would really say the best thing that we could do now is to be consistent within our own centers. At least let's make sure that all three of your registrars are doing it the same, or that we're all doing it consistently. But yeah, I would love a little more definition. I would love a little more specifics. I think they're going to answer, if you ask the questions to TQIP, they're probably going to read you these slides, which say generalized anxiety disorder. That's kind of what it is. But through the TQIP website, and again, you don't have to be a participating center, you can comment and leave recommendations about every single field in the trauma registry. So you can go in and say, hey, this field is very confusing to us, or we have patients X, Y, and Z. You can comment on these fields, and that is one way that they do make some change. All right, let's go back, or at least we have two more ahead, right? Well, there we go. All right, good. You guys are good. I love the questions. Number 9, pre-existing condition dementia can be assigned to any patient arriving from a skilled nursing facility with an altered mental status and a history of confusion. All right, let's go to the next slide. Yeah, I would say no. I would consider that false. I would try to look for some other documentation, but they really must have diagnosis of dementia. They offer some different words in here, but those of us who occasionally, as we've aged, have trouble finding a certain word do not get the dementia diagnosis, right? So there really has to be a diagnosis in the record. I would just point out that dementia does not equal delirium, and delirium does not equal dementia. Where we can help our trauma centers is in terms of if someone comes in delirious and they come in confused and agitated, making sure that that is well documented so that they don't get the hospital event of delirium when they came in with it. But a demented patient can develop delirium. So just bear that in mind. I see another question, but I'm going to wait till the end and then I'll go back to that. Thank you. All right. Final one, number 10. Pre-existing condition of substance abuse disorder should be assigned to patients who report a history of opioid abuse, now managed with Suboxone. Let's go to the answer of that one. And the answer is true. And this is a slight change, right? Over the years, there was a time when they didn't want us to extrapolate a bit, when the definition was a little bit more rigid. But the current definition says, or a diagnosis of any of the following, right? Documents consistent with the diagnostic criteria, blah, blah, blah. So it's good. I think, again, this is one of those ones where perhaps there is some underreporting. I know that sometimes my own trauma surgeons are like, yeah, I'll just write that he takes methadone. I'm not going to call it a substance abuse disorder. That's not me, right? Similarly, the language for the alcohol abuse disorder is very similar to this. And again, I would just remind us that somebody who scores positive on your screening and brief intervention and referral to treatment for alcohol, that does not equal alcohol use disorder. And a positive ETOH level does not automatically equal alcohol use disorder. So these are all distinct things. And we all have to make sure that we're using those definitions the same. Next one, we're almost done. You guys are hanging in there with me. All right, here's a couple more questions. This is again from that FAQ document, where again, this first question talks about that they broadened it a little bit, right? Descriptors documented consistent with diagnostic criteria, specifically, blah, blah, blah. They've sort of broadened it a little bit. And then in typical, TQIP fashion, if you ask them, where can I get more information? They say, go back to the APA. If you read that document, it's a very long document. It doesn't help me very much when it comes to charts. Next slide. All right, strategies. So here's my suggestions. First of all, I think that we have to take the annual update really seriously. Like, that is someone's job in your trauma center. Like, you get it first, you update us, you see, blah, 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 right? Conversations with the clinical staff if definitions have changed. Conversations with your software vendor to make sure that you're getting the upgraded lists and the upgraded choices. I would say, again, utilize the TQIP resources. Their educational resources are pretty good. And they do usually put out some updates every year when the new dictionary comes out. Next slide. Maintaining a master log. I like the term master log. People call it different things. But to me, sorry, I'm just looking something up. To me, just keeping track of when things changed, particularly our internal fields. The NTDS keeps a master log for us, a change log of the major differences in the dictionary. But when we add those internal fields on our own hospital, or when we decide to start tracking some new procedure, or we have new staff join, just keep track of that, major changes. You built a new ICU or you built a new ER. Keep track of that in some sort of a logbook, because it's going to help you explain your data as the years go by. Next one. This is just my helpful hints from Jane. Get the clinical team on board, right? They need to do this. My proud moments are when my trauma surgeons sit at peer review meetings and say things like, well, it looked like a complication, but it didn't meet the criteria. And you're like, yeah, you know the definitions. Same thing with pre-existing conditions, right? If you can tell them, guys, instead of writing takes Xanax, could you write generalized anxiety disorder takes Xanax? That's going to help us to put the patient in the appropriate pre-existing condition box. Then, sometimes you'll get a little bit of buy-in with that. The tertiary survey, many trauma centers have their team see the patient like 24, 72 hours after injury to get a better history. And sometimes really reinforcing with them that could you get a med history at that time, or even teaching the registrars that's a good document to seek out. That can be helpful. And having a clear data hierarchy, that does a huge service to your registry staff. If you can tell them, here's the data hierarchy, like you're not going to find that in a, nutrition service note. You're going to find it in the orthopedic surgery note, period, end of discussion. And the last one, I think I have one more suggestion. Next slide is validate selectively. So again, validating pre-existing conditions should be part of our data validation plans within our registry because they are so important. But you can validate, you can do the old 10% of your charts, validate every field. That's one way. Another would be to look at your TQIP data. If you're a TQIP center and pick a group, our TBI patients or our isolated hip fracture patients, how do my pre-existing conditions compare to the rest of the countries, to similar hospitals? Are we in the same ballpark? Or, do I have twice the rate of something or half the rate of something? Maybe my patients are that different. We just did this recently in my region. We took a look at things, and smoking, pre-existing condition smokers in New York State is half of what it is in the rest of the country. New York State has had a lot of anti-smoking campaigns over many, many years. It's probably correct data as opposed to another state that maybe hasn't had that. But in terms of elderly patients who are hypertensive on meds, one would think our rates should be similar. So that's another way to validate selectively and just kind of strategize. All right, last slide I think is coming up. I just wanted to thank you guys for your attention. And I appreciate the opportunity. I just want to go back. Somebody had a question about, oh, man, there's a lot of questions, you guys. I got to figure this out. Hang on. Somebody had a question about prematurity.
Yeah, so I can go through them for you. So
sure.
The last question we left off on, can you please look over question 3 again in regards to prematurity?
So report only on patients under age 15 and diagnosis delivery before 37 weeks. I don't even remember exactly what the question was, to be honest, but I'll go back. It was way at the beginning. My question was the pre-existing condition of prematurity should be assigned to patients under age 5. Well, oh, I see what you're saying. I got it now. Yes, it should be assigned to patients under age 5, but I probably worded the question poorly. I was thinking only under age 5, and it should be under age 15. Prematurity should be looked at for all pediatric under age 15 patients. So yes, correct. Under age 5 is also included in under 15. A poorly worded question on my part.
Let's see. And then I have patients that come in often with dimension confusion in the beginning with agitation, but then a few days later it becomes bad enough that a sitter is needed. Would you consider this delirium?
I don't have. I wouldn't assign delirium just because someone needed a sitter. There would have to be some other documentation in the chart, like a CAM score, right? There's some screening tools that your hospital uses. You should probably have a delirium guideline, right? Somewhere where this is what we're going to do. And I would look to see that somebody put a diagnosis of delirium in the chart. I wouldn't just automatically on a sitter assign delirium. No.
Okay. And then we have, if the patient reports meth use or any other medication, can we report substance abuse disorder?
If they report that they're a meth user?
Yes.
Well, let me look at the dictionary. I would want to see that there was documentation, and this is where the clinical team is so important, right? Because you don't want to be assigning pre-existing conditions because somebody said something and, like the EMT wrote it down in the ambulance, and you're not going to take it from there. It has to be part of the diagnostic milieu of the patient, as it were. I'm sorry, that's not a good answer. That sounds like a bad answer. I'm kind of hedging because it has to be substantive. That yes, we know this is really true, and we've treated the patient as such, and and then there should be a diagnosis, and you're going to have to talk to your clinical team and say, you guys have to learn to write these words down. Does that make any sense?
So it looks like this next question might be in that same answer, but I'm going to say it anyway, and you've let me know. For substance abuse disorder, if they document that a person admits to marijuana use every day, would that be code, or under substance abuse, they document marijuana use?
Yeah, again,
I think it goes the same thing.
Yeah, sorry. Yeah. And again, I'm sorry that sounds like hedging. It is a little hedging. I'm trying to be respectful of what the National Trauma Data Standard says, and I don't speak for them, right? So these are great questions, but to make sure that we all stay within our wheelhouses and in our lanes, I would refer some of those questions to the NTDS or to TQIP. I think there needs to be, they need to hear these questions. They need to hear what's documented and what isn't documented. And that's how we make the system better.
So this goes under substance use as well, but I think it's a slightly different question. For alcohol use disorder or substance use disorder, would you report these comorbidities if dependency is documented, i.e. alcohol dependency or abuse instead of alcohol use disorder?
Yes.
Okay.
Yes.
Perfect. Simple answer. Let's see what the next one is. I'm reading functionally dependent should always be yes if they are in an assisted living and skilled nursing facility on the FAQ. Am I reading this wrong?
Again, I would not want to speak for the TQIP. I would ask them the question, but I would not. If someone's in a nursing home, then I'm really going to dig through that chart to find out what is it that they're getting assistance with that will qualify for them for functionally independent health status. The range of services in assisted livings is so varied that I would not want to assume that, it's not that they're getting help with meal prep, it's getting help with feeding, right? So like one could argue that in the pandemic when we all ate out every day and had taken, right? So it's really that they need help feeding. So I would want to dig in those notes. And again, sometimes care management, social work, physical and occupational therapy, they're the ones that might really be able to tease out that level of support that the person is getting.
Okay. So it looks like we have a lot of thank yous that you should go back and look at after this. And a question that was answered by someone else and you while you were answering another question, I think. So I know we record this that people can go back and look, but do we give copies of slides to participants?
I'm happy to share my slides, so that's fine.
Okay. So it was an unknown user that wrote that, so I can't see who that is. So I know, Jane, you said you put your email in the chat somewhere, so I would suggest emailing Jane, and she can get you those slides if you're interested. And does anybody have any questions or any more? That was already a lot.
No, that was great. I love it. Because I think the questions reflect that this is not an easy science, right? This is not just yes or no. There's a lot of interpretation of the record that you guys are doing every day. So we need to try to make that as easy as possible for ourselves. We need to teach the clinicians so that they know what they have to do. And yeah, that's great. So again, thank you guys so much. You're a wonderful audience. Thank you for the computer assistance, Amanda. I'm sorry, I don't know what happened to us today.
No problem. And I'm seeing that other people are requesting the slides get sent to everyone. Like Jane said, I am not the Amanda that originally set this up, but I think there is a way that we can see everyone's email addresses. And if there is, I'll help out with trying to get these slides to everyone as well. So thanks for joining us, everyone.
Thank you all.